ECHO COVID-19 Global Conversations. I'm Matt Bouchonville. I'm a diabetes specialist and one of the associate directors at the ECHO Institute in New Mexico. And today we are honored to welcome Drs. Satish Gopal, Sharon Kapambwe, and Dr. Pramesh for COVID-19 and cancer care. And before we get started, I want to remind those of you who are joining us that we have Spanish and French interpretation services available. So you can actually follow this conversation through an interpreter if you wish. Additionally, for the question and answer function, if you're submitting questions through the Q&A box at the bottom of the screen, you can submit your questions in Spanish or French, and the interpreters will submit your question to the speaker for you in English. And so as a review, and for those of you who are new to this series, you can click at the bottom of the screen. There's a small globe icon at the bottom of your screen that says interpretation. You can click on that, and then that will pull up the options of either Spanish or French. And then you just click on your preferred language, and then you'll have the option to hear only the interpreter, or you can choose to hear English softly in the background. And we're very excited about this topic today. We've had over 1,000 people register for the session, and we're grateful for the time that you've taken out of your busy schedules to join us. I will be assisting and handling the live questions that you're submitting during the session, during this webinar, and this will be in collaboration with Dr. Sanjeev Arora. Sanjeev?
Hi, this is Sanjeev Arora, and I serve as the director of the ECHO Institute here at the University of New Mexico. We're really honored to have all of you join us from all over the world. The purpose of this global conversation series are essentially two. One is to we want to disseminate science-based information all over the world. And second, we would like to set up a collaboration between different countries to share best practices that they have come up with in the COVID-19 field. And this, of course, session is going to be very specialized on cancer and COVID-19. But thanks to all the panelists who've accepted our invitation to join us. And thanks to Dr. Satish Gopal, who's the director of the National Cancer Institute Global Division, to moderate this session. Over to you, Matt.
All right, thank you, Sanjeev. And let's continue with a round of introductions. And while our panelists are introducing themselves, you'll be able to find their bios in the chat box. And let's begin with the moderator for today's session, Dr. Satish Gopal.
So thanks, Matt, and thanks Sanjeev. I'm Satish Gopal. I'm the director of the Center for Global Health at the National Cancer Institute, and I'm really delighted to participate in this important session this morning.
Thank you. Sorry about that. My phone was ringing. And thank you, Dr. Gopal. Dr. Sharon Kapambwe, if you can please introduce yourself.
Thank you so much for this time. My name is Dr. Sharon Kapambwe. I'm currently the Assistant Director for the Cancer Control Unit at the Ministry of Health in Zambia.
Wonderful. Thank you, Dr. Kapambwe. And finally, Dr. Pramesh.
Yeah, hi. My name is Pramesh. I'm the director of the Tata Memorial Hospital, and I'm also the convener of a very large network of cancer centers in India called the National Cancer Grid. Pleasure to be part of this important meeting.
All right. Thank you, Dr. Pramesh. And in an effort to keep this session as interactive as possible, we have plenty of time dedicated to question and answer. So the structure of this session, we will have Dr. Gopal presenting a global overview of cancer and COVID-19. And then Dr. Pramesh will talk about treatment adaptations at the facility and cancer network level. And finally, Dr. Kapambwe will discuss the impact on public health screening and primary care level strategies. And so again, there will be plenty of time for moderated discussion to keep this as interactive as possible. So please send us your questions as we go. And then finally, before we begin, we have some housekeeping items to address. And so as with other such sessions, we will be recording this session, and you'll be able to find the session on our website. Please note that it can take up to 48 hours for our video team to upload the recording and the slides from today's sessions, but those will be available soon. Please also note that because of the large number of participants, we will have all of the participants in listen-only mode for the session. Also, with respect to the question and answer, we have already received almost 200 questions during the registration process, and we thank you for submitting those. We also anticipate getting several live questions as we go. So we do apologize in advance that we will likely not be able to get to all of these questions, but we'll get through as many as we can. So thank you for submitting those, and please keep them coming as we go. I alluded to this earlier, but at the bottom of your screen, you'll see a chat box and a Q&A box. We ask that you submit your questions in the Q&A box. And the chat box, keep an eye on the chat box as well. Don't submit your questions in the chat box, but what you're going to see there is a number of resource links, and they're already coming across right now in the chat box. So you'll see several resource links applicable to the presentations that are generally put into the chat box by the ECHO digital librarian. And then also at the end of the session in the chat box, you'll see a link to the survey that you can complete to provide feedback and also to obtain your CME and CEU credit. So I think without further ado, we'll hand over to you, Dr. Gopal. Thank you.
Great, thanks so much, Matt. Could I get my slides up?
Rigid.
All right, in just a moment, we'll have your slides up, Dr. Gopal.
Sure, so I guess while waiting, I'd just like to, again, thank Sanjeev and Matthew and the entire Project ECHO team for inviting me to moderate this global conversation focused on cancer and COVID-19, along with Drs. Kapambwe and Pramesh. I think this is a critically important issue for us to be addressing this morning. Before we have an opportunity to learn from, I think, very important real-world experience that my colleagues will share, I wanted to start first by providing just a little background related to cancer and COVID. Next slide, please. So I have no financial disclosures. Next slide. So over the next 10 minutes or so, I would like to review these 4 learning objectives, which reflect some of the primary ways in which I believe COVID and cancer have intersected globally. So I hope to briefly cover the scale of COVID disruptions to cancer control and research worldwide, and the possibly increased risk of COVID infection, morbidity, and mortality among cancer patients. I would also like to briefly review data for use of treatments for COVID that have been classically applied to cancer patients. And finally, discuss potential improvements to cancer service delivery that may be accelerated by COVID-19. Next slide, please. Undoubtedly, and as reflected in our virtual participation in this event from our homes, COVID has affected essentially all aspects of our lives, including the ability to continue cancer services and research. Next slide. So shown here is a figure from a recent editorial by Dr. Ned Sharpless, the NCI director, in which NCI colleagues from the CISNET modeling group estimated nearly 10,000 excess colorectal and breast cancer deaths over the next decade from COVID-19 related disruptions in the United States. Moreover, these projections almost certainly underestimate effects of the pandemic on cancer control, as they assume modest and time-limited disruptions to routine services and examined only 2 common cancer sites. Next slide, please. Taking a more global view, the data to inform, while similar modeling efforts are ongoing worldwide, the data to inform such models in LMICs are simply not as good yet. And healthcare infrastructure in many LMICs was insufficient to meet cancer control needs even before COVID-19. This figure shows a compilation of estimates largely from the WHO, summarizing anticipated effects of COVID across a variety of health domains. While unsurprising, such projections are certainly sobering. For cancer specifically, and this is shown in the red box at the bottom, a recent survey of countries found disruptions in cancer services in 42% of countries, and even higher rates of cancer service disruption in countries with ongoing community transmission of COVID, disruption levels of up to 50 to 60%. Importantly, this survey was conducted in May, before COVID cases really began to steeply escalate in many LMICs. So while we will learn more, it is unavoidable that COVID effects on cancer control worldwide are likely to be profound and long-lasting, and an ongoing challenge for the global cancer community for years to come. Next slide, please. The economic consequences of COVID are also already having a marked impact on the rich community of international cancer research funders, with nonprofit organizations from the International Cancer Research Partnership particularly predicting substantial losses of income this year. Many organizations are anticipating such funding shortfalls to continue even beyond this year. Next slide, please. So just as COVID is affecting cancer control systems, it is also affecting individual cancer patients who may be at increased risk of infection and complications. Next slide. Shown here are early data from China, providing one of the first signals related to potentially important interactions between cancer and COVID at an individual patient level. In this nationwide analysis, approximately 1% of all COVID cases as of the end of January had a history of cancer, which was higher than the overall cancer incidence in China in 2015. Cancer survivors and those with active cancer were also noted to have a substantially higher incidence of severe complications from COVID compared to those without a history of cancer. Next slide, please. Significant COVID-related morbidity and mortality among cancer patients has also been described in the CCC19 cohort, including cancer patients with confirmed COVID from the US, Canada, and Spain. This was observed for both solid and hematologic malignancies, and particularly among patients with advanced and progressing cancers, for whom mortality was in the 20 to 30% range. Next slide, please. The intersection between cancer and COVID goes even further in that some treatments approved for cancer indications may have therapeutic benefit for COVID patients. Next slide, please. So as one example, BTK inhibition has been hypothesized to potentially have therapeutic benefit in severe COVID-19 by reducing hyperinflammation and macrophage activation. In this observational study conducted by NCI colleagues, the BTK inhibitor acalabrutinib was associated with reduced inflammation in patients with severe COVID, as evidenced by the declining trajectory in C-reactive protein shown by the red lines across multiple patients in the figure at right. This was accompanied by concurrent improvements in oxygenation, as shown by the blue lines. This class of agents and others familiar to oncologists are currently being further investigated for severe COVID. However, I want to strongly emphasize that these are not broadly accepted standards of care for COVID, and also the continued need for high-quality clinical trial data to rigorously evaluate these approaches. I would strongly encourage their use solely for proven indications outside clinical trials, particularly when more broadly applicable interventions like dexamethasone have much higher grade evidence to support their use as a standard of care for COVID-19. Next slide, please. The last point I'd like to emphasize in my brief opening remarks today is that we are all very hopeful that as COVID is controlled, this immense worldwide disruption will provide lessons and opportunities to improve ways in which cancer services have been historically delivered. And I believe my colleagues will provide some important real-world examples of this in their remarks. Next slide. As just one example, it is clear that COVID has had marked effects on cancer screening in the US. The figure at right from the Epic Health Research Network indicates that although the number of weekly screenings for breast, colon, and cervical cancer as of June were recovering, they were still not back to pre-pandemic levels. And there was a substantial deficit of missed screenings that will still need to be addressed. These problems have drawn significant media attention and also galvanized efforts to not just return to pre-pandemic norms, but to actually innovate to deliver more patient and community-centered cancer screening. For example, by accelerating efforts to approve HPV self-collection for cervical cancer screening in the US. Comparable efforts to innovate and investigate new ways to deliver cancer services that actually reach the populations that need them are being similarly undertaken with respect to increased clinical trial flexibilities and widespread use of telehealth. Such efforts are ongoing worldwide, and the NCI is deeply engaged in these initiatives across cancer sites and disciplines. Next slide, please. I'd like to also just highlight a number of websites that are very actively maintained by the NCI, CDC, and NIH, which are excellent resources for up-to-date information related to this rapidly evolving situation. Next slide, please. And finally, I'd like to just acknowledge the important role that Project ECHO has played in meeting some of the challenges I've outlined in my brief talk, as they were, of course, doing virtual telementoring and dissemination even before COVID and even before it was cool. Shown here is an Africa Cancer Research and Control ECHO series focused on COVID, which we at the NCI Center for Global Health have helped coordinate in recent months with numerous partners. And it is clear that such platforms are even more a part of our collective future than ever before. So with that, I'll stop there and would be happy to take a question or two before moving on to Drs. Kapambwe and Pramesh in our panel discussion. Thanks again for the opportunity.
All right, outstanding. Thank you for that overview, Dr. Gopal. Sanjeev, do you want to take the first question or two?
Sure. I think we have a general question about how do we make sure that certainly there's been a lot of disruption right now in in cancer care, as you pointed out so beautifully, Satish. What steps should be taken so that in future pandemics, this kind of problem can be avoided? And this is a question coming from South Africa, from Cape Town, South Africa.
So thanks, Sanjeev. I think that's a really important question, and I think both Drs. Kapambwe and Pramesh will have a great deal to say about this as well, and would like to revisit this in the panel discussion at the end. I think part of it is building, resilient health systems. I think this was also alluded to in some of the questions that we saw. And I think, to me, there's several aspects of, having a resilient health system. One is having flexible science-based policies and plans where we can sort of learn from things that are working and that are not working and make the appropriate adjustments. I think a really high level of community engagement is really important for health system resilience. That is when I think we've seen when sort of their messaging breakdowns or loss of trust between providers or policymakers and the communities that serve, that I think really undermines the resilience of health systems to continue, providing continuous cancer services. And I think, as I alluded to at the end of my talk, I do think there are real opportunities for innovations in implementation science and health systems delivery research. Again, with the aim of really providing the right service to the right patient at the right time. And again, I want to just call out ECHO, because you all have been focused on this for, well before COVID. So I do think there's a real opportunity to use, some of these novel tools to improve resilience within health systems and for cancer control specifically.
Thank you. And a specific question from Dr. Ikenola Ibadan from Nigeria. What is the impact of COVID-19 on HPV vaccination among adolescent girls?
So I'm going to defer that one. I think Dr. Kapambwe will have something to say about this in the Zambia experience specifically. So I think if it's okay, I think I'd defer that one to her talk.
Lovely.
Excellent. And there are some excellent questions coming across that are fairly disease specific that I think will be great once we get to the group Q&A. So Dr. Gopal, back to you.
Great. So thanks so much, Matt and Sanjeev. So I think with that, we can go ahead and proceed to the next talk. And that is Dr. Pramesh. Again, he already introduced himself, but he's the director of Tata Memorial Hospital, as well as the National Cancer Grid, which I think is a truly amazing network that has really been built from the ground up in India and is addressing a lot of important issues that are raised on this conference today. So I look forward to Dr. Pramesh's talk. Pramesh, please take it away.
Thank you, Satish, and thank you, Matt and Sanjeev, for the opportunity to be part of this wonderful meeting. So what I'll do over the next 10 minutes is to take you through the story of how COVID-19 hit India, what the impact and the kind of response that we had to do at a hospital or a facility level, and subsequently what kind of modifications we had to do with our cancer care. And finally, I'll end with how we helped disseminate this through the length and breadth of the country through the National Cancer Grid. So I have no financial disclosures with the content of this talk. So our first patient was diagnosed towards the end of January. It seems a lifetime away. And we had a fairly slow increase initially. Many would debate that this was probably because of the low levels of testing, but nevertheless, the increase was fairly slow to start with. And that's something similar to what many other countries have seen as well. But what was unprecedented and distinguishes COVID-19 from several other pandemics we've had in the past is that it caused widespread panic, and the response that we saw was in some ways disproportional to what the actual risk was. It also didn't help that it coincided with rapid risks in several other countries. Italy and Spain were remarkable in the way they climbed. And this resulted in a series of lockdowns of varying severity starting the 24th of March. And most hospitals, probably tailored to the kind of response that we had in other countries in the West, went down to shut down routine and elective services. So today, about 6 months later, we are at close to a 5.5 million confirmed cases of COVID-19 and close to 90,000 deaths. And things are very different today from what they were towards the end of March. In March, we were faced with a virus pandemic that we didn't know much about. We didn't know much about how it got transmitted, and you might have seen reports from the WHO and the CDC, which came up with new findings as recently as last week. We didn't know much about how we could prevent it, what kind of testing strategy we should have, and what kind of care should be provided. And several of these issues remain alive even today. As I mentioned, there's been widespread panic amongst the general public, the hospital staff, patients, all of which had major impacts on the way we were able to provide cancer care. Combined with this was a fairly stringent national lockdown, which started towards the end of March, wherein travel, accommodation for patients, even something as basic as food, got to be quite a big challenge. And that was part of some of the responses that we had to make as a hospital. And to compound all of this was the shortages with several supplies that we had, like PPEs. So we didn't have much time to respond, so we hit the ground running. And some of what we did, the principles are summarized in this slide. What to me was key was excruciating levels of planning. We had practically daily resembling war room meetings, which lasted an hour to an hour and a half every single day, and we continue it even to this day, with the need to make decisions which needed to be changed very quickly. We couldn't rest on decisions we made yesterday, and even on an hourly basis needed to make changes with some of the major decisions that we took. Again, something that was key was employee communication, and to this date, it remains one of the most important aspects of why we've been successful at what we've been doing. Anticipating events is easier said than done, especially when you're trying to deal with a virus as wily as SARS-CoV-2. But to me, what has been key has been the creation of teams which each takes responsibility for one aspect of our overall response. And this has brought in a lot of champions, which from very unlikely sources. Some of the employee-directed initiatives that we took, as I mentioned earlier, was open, transparent communication. So this started with face-to-face meetings, but very, very rapidly evolved into virtual meetings, given the increasing evidence to support distancing as a measure to reduce transmission. We identified a number of high-risk employees, those who had organ transplants, those who were patients on chemotherapy, pregnant women, and gave them fully paid leave to ensure that the most vulnerable was protected from exposure to the virus. We also had to be prepared for a staff sparing policy, wherein in case of a mass epidemic within the hospital, we had the necessary bandwidth to replace a large number of people or staff quarantined with other staff. The patient-directed initiatives were predominantly crowd mitigation strategies, and anyone who's been to the Tata Memorial Hospital will realize how big a challenge this is. We see close to 3,000 patients every day visiting the hospital in a very small, extremely crowded part of Bombay. So we had to resort to screening stations outside the hospital, trying to create distancing. We very rapidly initiated a policy of teleconsults, especially for those who were on follow-up. Some of the areas where we needed to change our hospital policies, we are a predominantly or a completely cancer hospital, so we needed to be prepared for an infectious pandemic and come up with new SOPs for COVID-related activities. So we needed to create a new fever clinic and isolation ward. Some of our cancer wards were converted into infection wards. And we had to come up with COVID-19 testing, which involved a fairly major logistic challenge, but we were able to do it in 3 days flat, and in the bargain get clearance to do the testing ourselves. We also had to manage the national lockdown, which meant that we had to arrange transport for our staff because there was no public transport available, and where 90% of our staff traveled by public transport, this was a significant challenge. Similarly, most patients used public transport. Again, we needed to arrange for their transport. We needed to do something as simple as arrange for food for family members of patients who were admitted to the hospital, because none of the restaurants outside were open. It came to as detailed discussions as that. And we had to come up with hospital hotels close to the hospital where we could house patients and staff when necessary for treatment. This is one of our screening stations, as you can see, outside the hospital. Though we didn't know at the time that being outdoors was better, this was something that was fortuitous and necessitated by the crowded nature of our own hospital. So what we were very certain about was that we would share our best practices very quickly. So we published this within 2 weeks of starting all our interventions towards distancing and the strategies that we took, and to a large extent guided the nature of how other cancer centers in India handle the pandemic. The next aspect that we needed to deal with was how would we modify cancer treatment during the COVID-19 pandemic. And we realized that we not only needed to do this for our own center, but also provide guidance for the larger cancer community in India. And we were clear that it needed to be individualized as per the institution and the patient details, and it could not be prescriptive. So we came up with broad principles on which centers could decide. And this is primarily based on what stage of the pandemic we were in, what was the likely trajectory in that region, the infrastructure available at the hospital, and what was the risk of COVID-19 to the patient versus the risk of suboptimal or delayed treatment for cancer. And this was a delicate balance between needing to continue cancer treatment for patients who deserved it and the need to ensure that the safety of our patients and our employees. And as I mentioned before, this was rapidly converted into a guideline for delivery of cancer care during COVID-19 across the national cancer grid. And as I mentioned, the broad principles we worked on was based on the fact that cancer care is not elective and needed to go on even during the pandemic. Though there were higher risks associated with treatment of patients with cancer, we needed to balance this against the benefits of prompt cancer treatment. And this was an exercise in shared decision-making with patients. We needed to rapidly prioritize care where the impact was more and led to a whole new version of choosing wisely for cancer. And all this adopting universal precautions for both our patients as well as our staff so that they could be protected. And we made sure that all of this was disseminated across the length and breadth of the country through the National Cancer Grid Centers. As you can see, these are the locations where the NCG membership is located. And these guidelines were disseminated. In addition, we had the support of several leading organizations like the US CDC, the WHO, and experts within India as well. We were quite clear that we wanted to make these series of webinars quite comprehensive. And as you can see from some of these topics on this sample webinar, we involved all stakeholders and made it a diverse participation, including the Government of India, guidelines on testing, on therapeutics, ICU management, psychosocial issues during the lockdown, and addressing mental health issues, as well as diagnostics and vaccines. We were sure to include the key players. Nurses have been at the front line of managing the pandemic across the world, and we were certain to make sure that they were involved in this. And again, we were sure that this needed to be disseminated across not only India, but several other countries which were in a similar situation across the world. So to summarize the basic principles on which we founded our strategy, it was planning, planning, planning to an excruciating level of detail. And as I mentioned, the daily war rooms, which we continue to this day, have been a huge bonus. Employee communication has been free. We were very transparent with sharing data, with sharing progress that what we were doing. We were also challenged with ensuring supply chains. We had to optimize the use. The N95 shortage is a classic example. We managed this through very innovative methods like extended use as well as reuse of N95s, which again we disseminated across all the other centers so that they could benefit from our own experience. And we had to look at fairly unconventional solutions like organizing buses to transport our staff from various parts of our city to the hospital and back. And at one point, we were running 66 buses just to transport our staff from back and forth from home to hospital and back. And the hostels were an entirely different aspect, because we were able to leverage the fact that hotels were virtually empty, and we were able to get hotel rooms at throwaway prices so that we could host not only our patients as well as our staff so that they could reach reach the hospital quickly. There have been a lot of silver linings in this pandemic, and I'm an eternal optimist. And I look at what has been forced as an increased attention to infection prevention and control. And initiatives that we were trying for years together have suddenly got compressed into a 6-month period where every single member of the staff and including the patients have become attentive towards best practices in infection prevention and control. We've been able to prioritize treatments, looking at high impact treatments and prioritizing them over marginal benefits. And this is something that's extremely important in low middle income countries where public healthcare expenditure is pretty low. We've rapidly adopted tele and video consults, which again have been of extreme benefit to our patients and have optimized the time that our physicians have to spend. And what has been very encouraging has been the remarkable collaborative spirit with which many organizations have worked, the interdisciplinary multinational effort that people have put in towards both prevention and for therapeutic research in COVID-19. So I'll end with this. What do we do now? The problem that we are currently facing, as opposed to what we faced 6 months back, is a fatigue with all these precautions that we've been forced to take over the last 6 months. Unfortunately, the virus is not fatigued, and therefore our emphasis is still to stick to the basics, the 3 W's: wear a mask, watch your distance, and wash your hands. We need to wait for the vaccine, admittedly with the caveat that it's not likely to solve all our problems. It's not a panacea. We need to look at both the safety and the efficacy, and we need to continue research on therapy. And I realize this right now, the pun was completely unintentional, but science should certainly not trump politics. These are some of the references which I'm happy to share with all the participants, and happy to take any questions either right now or towards the end when we have a common Q&A.
Thanks so much, Pramesh. I mean, that was amazing to review everything that you all have accomplished. So congratulations on that. So I don't know, Sanjeev or Matt, is there a question or two that would be particularly urgent for Dr. Pramesh's talk before we move on to Sharon?
Thank you, Dr. Gopal, and thank you, Dr. Pramesh. I think the questions that have come across will be best for the end on my end. Sanjeev?
I think that works for me too. I think, Satish, if that's what you prefer, sure.
Okay, sounds good. So why don't we move on then and look forward to a rich discussion amongst all of us at the end. So our next speaker is Sharon Kapambwe, who may be well known to many of you. Again, one of the things I was delighted by was Pramesh and Sharon are both people that we'd love to hear from, even under usual circumstances. And I think their experience, leading these large national programs over the last several months, I think is particularly salient for us now. So Sharon is going to talk a little bit about sort of mitigating public health effects of COVID to provide a nice complement to the more hospital and kind of referral center perspective that Pramesh gave. So Sharon, over to you, and thanks so much for joining us.
Thank you so much, Satish. Bridget, I can have my slides, please. So while I'm waiting for the slides share, thank you. Thank you so much for this time. I find it really a privilege that I can be able to talk about COVID-19 impact on public health screening and care level strategies. As I have been introduced, I'm currently the Assistant Director for the Cancer Control Unit for the Ministry of Health, Zambia. Next slide. So I really want to start with giving the background of Zambia and COVID. First and foremost, Zambia is found in the South Central Africa. And one key thing about our country is that it is land-linked. We are surrounded by 8 other countries. That is quite an important aspect when it came to COVID-19 in our country. Our first case was recorded on the 18th of March. And as you can see from these slides, we see that we started having a kind of spike in July and in August. And we've been seeing that we're slowly going down as we've been going in September. As of today, we have seen over 14,000 cases in Zambia, and we've had 327 deaths. Of course, 111 cases are COVID-related deaths that we have in Zambia. Next slide. Like I said, as you can see, we are surrounded by 8 other countries, but I wanted to show this slide just to be able to see that we still have some districts in our country that still haven't reported any COVID case. But you can see that we've had some parts of our country in the northwestern of our country, in the capital as expected, and some parts in the northern parts of our country that have had much higher numbers of COVID compared to other countries, to other districts. So this is just to show that we really have a widespread community transmission. Next slide. When we look at this percentage distribution based on age and sex of COVID-19, this was at the time we had 10,000 cases, 10,738 cases when the assessment was done. One key thing that I want us to look at is we're having the highest numbers in the age range of 25 to 39 and 40 to 59. Of key importance, especially for our cervical cancer screening program, is that our eligibility, women eligible to screen, is also between 25 and 59. And that has an impact in the way we do our intervention or the impact of COVID-19. Next slide. So before I go to the cancer screening impact, I thought we should take a more holistic view and really looking at other types of public health interventions that could have been affected by COVID. So if you look at this slide, we're looking at the under 1 child health attendances. So we are comparing last year, January to July, and we also get to compare January to July 2020. And if you look at this slide nationally, last year, where we had about 77% of under 1 child health attendances, when we look at what we're looking at up to July this year, we were at 67. So we see a 10% drop in under 1 child health attendances. This is important because when we look at cancer screening, we're really looking at people who are otherwise healthy and are coming for screening. And this is the same for the children, most of them who are being brought for these under 1 child health intervention, mostly for vaccination or other kinds. So if people are coming and we're seeing a drop, this is likely to be a reflection of other interventions as well. Next slide. If we look at family planning attendances as well, looking at the same periods that we looked at for the under 1 child health attendances, you will see that we had 87.1% last year at the national level, and we see that it's come down to 69.2%. And you can see in the capital, which is Lusaka province, that's the capital city, and that's the capital city is found in Lusaka province, and the capital city is also called Lusaka. So you see in that province a drastic drop as well to 41%. From almost 60%. That's the most highly populated, and followed by the Copper Belt as well, which is highly populated as well. So this has an impact on our screening program, in that we see some of the women who come in for screening are actually coming for family planning attendance as well. Next slide. So I want to take a bit of time on this one. I know there was a question that was raised. Zambia started its national HPV vaccination program last year. So you see HPV-1 is when we give, and I must say these are preliminary results because this is what the HPV vaccination is carried out during what is known as Child Health Week. Which is a week where we intensify the monitoring of children and deworming or some vaccination. During this year, we also gave IPV for these children. This time, remember we had our first case on the 18th of March. And after that, there were presidential directives that were done. One of them was closing of schools. And our HPV vaccination program is a school-based program. That means up to now, the schools are just opening now in our country after being closed for almost 6 months. So that meant that the girls that were supposed to receive HPV vaccination, it was supposed to be, we vaccinated in June, they were not in school anymore. And as you can see, the first round, we had about 82% coverage, and we came down to about 65%. This year at the national level. And you see that there's basically all the 10 provinces that we have in the country had a drop during this time. And this is the time when schools were closed. I'll talk about the interventions that were done in the later slides, but this was to show that our HPV vaccination program was affected, and we saw a reduction in coverage of these young girls. And we are vaccinating 14-year-olds in our country, and we did not reach the target. We did not reach the target which we had set then at 18% before we started. Now we're moving on to 90% as per cervical cancer elimination agenda that we have, the strategy of ensuring that 90% of the girls by the age of 15 are vaccinated. Next slide. So this is how the coverage is. You look at HPV-1, we did have a few. If you look at red, that means that we had low coverage in those districts. Green is where we were reaching our targets, and yellow was just in between there. If you look at HPV-2 coverage, you will see by district that we have more districts which are giving us red. And what we do, HPV results for additional 21 days, is that after we finish the intense 1 week Child Health Week, we have an extra 21 days where the girls can be able to get vaccinated at health facilities. So during COVID, we saw a reduction in the number of girls who were getting vaccinated for HPV. Next slide. So then we come to the main issue, and we have a big population-based cervical cancer screening. We are almost at 90% in every district in our country, and we've got over 115 districts. Of course, the bigger districts have more facilities for screening. So this was last year, and this is for HIV positive women, and I'm going to give a reason why we've looked at HIV positive women, and we look at 2019 in about 4 provinces. And you will see that by June, July, we were going above the targets that we had set. And at the end of the day, we did go to close to 90% of the target that the country had for the number of HIV positive women that were supposed to be screened. And for the HIV positive women, we look at the different 25 to 49. Next slide. When you look at this year, and we looked at 2 of the provinces, you look at April and May, look at the dip that has happened in the country. So you find that all of a sudden at April, our first case 18th, the president a week later gives presidential directives, and immediately we see a drop in the number of women coming for screening. Next slide. So this is what happened. From the slides, we can see that definitely there's been a negative impact of COVID-19. Countrywide impact has been observed. What could be some of the issues? We started with the slogan, stay home, keep safe, stay at home. So people took it that they needed to stay home and they didn't come for screening. And then you find that there was a fear of getting COVID by coming for screening. And you find that even in our intervention, we were more skewed to the curative other than to the screening processes, and women feeling like, I'm okay, if I go there, I might get COVID. And then to an extent, there's also the issue of personal protective equipment that comes into play. Next slide, I think that should be the last. What are some of the strategies that we've used? Multimedia messaging to be able to say there is continuation of routine health services. And also the ministry has come up with the development of guidelines for these routine health services to ensure that we're looking at them. And for cervical cancer screening is also targeting women who are already in the facility. You're looking at women who are HIV positive, you're looking at women who are coming for family planning, you're looking at women who are coming for child health clinics, and having outreach in brackets to high volume clinics as well. And ensuring that we can use this time to also follow up women. We're doing self-sampling for HPV testing as well. And anyone who hasn't been treated who was found with a positive result. Next slide. That should be the last one. So strategies were skewed at ensuring that we look at things that we could be able to do to improve uptake of services, but we also look at our data, look at things that we haven't done in a long time, but it's also the inclusion of the visual aspect, starting the cervical cancer training with having the visual, the first part being visual learning, virtual learning, before we actually go back on the ground and have a one-on-one to reduce on people getting exposed to possible COVID during the training. So in summary, all I want to say, and I hope we can have further discussions after that, that we have seen a reduction in uptake of public health services, especially cervical cancer or cancer screening services, but we've also put in strategies to be able to mitigate that. Thank you so much. I look forward to speaking more in detail when we have the Q&A.
Great, thanks so much, Sharon. So, you know, I think like Pramesh's talk, this was another amazing talk from a real world leader in sort of cancer control, and who's played a particularly important leadership role, I think, in mitigating some of the effects of COVID at a national level. I wonder if there's a question or two specifically related to Sharon's talk, Matt or Sanjeev. There was a question about HPV vaccination among adolescent girls earlier. I don't know if Sharon, if you want to kind of elaborate perhaps a little bit more on, given the sort of deficits that you have seen or the missed opportunities for vaccination, is there a kind of clear catch-up strategy that you all are intending to pursue at the ministry level?
So one of the strategies is having the 21-day lead, like almost a month after the actual intense HPV vaccination. So we complete the vaccination in a week, but we go on to allow other girls who've missed this vaccination. One thing that I want to mention is that last year we had started e-registers for the girls. So they were being registered electronically. So this helped in that this year, when we asked for vaccination, because most of the schools were closed, is that we told the girls, the message that went out to the parents, to the community, is that the girl can get vaccinated from any school. It doesn't have to be a school where they go. Some go into boarding school, so they're not even going to be able to go, so they can go to any school. And because you have a presence of an e-register, you can be able to track that girl, even if she goes and vaccinates elsewhere. The good thing is you find that, so schools were being used, schools were open because there were some people in examination classes who were still present. So it was a great effort by the expanded program of immunization team, but also ensuring that you have registered the girls electronically prior helped us to be able to achieve even such numbers. Extending by 1 month also gives girls to have more time to be able to go to other places, and ensuring that. So from the data that I have, we're probably going to have new data, which shows improvement, but still not being able to reach the target that we had intended, but at least it has improved to closer to the target.
Great, thanks so much, Sharon. I think Matt has maybe one more question specifically related to your talk, Sharon, but before we perhaps open it up for a more general discussion. Matt?
Yes, thank you. Dr. Kapambwe, excellent talk. There's a question submitted directly to you from Ray Bridgewater. Where do you see the role of technology, advanced medical mobile units to provide this type of health screening and treatment in Zambia?
Sharon, you're on mute.
I'm so sorry. I'm so used to muting myself after speaking. Matt, I just want to get your question clearly. Is it the use of mobile units or electronic?
That's right. Medical mobile units. You got it.
Oh, yes. So when you look at medical mobile units, and we did have that in Zambia as well, what you need to put in mind, these are very, very important for hard to reach places, because there are some girls who are still, even if their schools are quite a distance. So the mobile units can come in ensuring that these girls are reached closer to their homes. Because we can have a school here and we find the next school is 10 kilometers or 20 kilometers away. I remember these are not sick girls. So the incentive to be able to go for vaccination becomes very difficult, just like screening. So if you have a mobile unit which can move closer to their home, that makes it much easier for you to be able to reach these girls. All that has to be ensured in the COVID case is ensuring that we reduce on the numbers that are coming at a time, or else you end up with a mob and you're not able to put some of the preventive measures. So having appointments and ensuring that you can control the number of girls and reducing the exposure to possible COVID if they come to the mobile units. And of course, human resource to be able to do that is another issue.
Great, thanks, Sharon. So one of the things we were hoping in sort of building this session was to really have some time for some group discussion. Again, I think Drs. Pramesh and Sharon have offered such kind of unique and complementary perspectives on this massive disruption to cancer control that we've all been experiencing. So I think we can open it up to some group discussion now. I think the questions are going to come from Drs. Bouchonville and Aurora, perhaps.
Yes.
And we can sort of take them and direct them as seems appropriate for the specific question.
Perfect. The first question comes from Vidya Vedham and directed at Dr. Pramesh, but really would like to hear all of your thoughts on this. But could you highlight the opportunities and limitations to using telemedicine in cancer care?
So thank you, Vidya, for the question. And I think it's useful, but that's a nuanced useful. It's very beneficial in those who are on routine follow-up and where the intensity of the consult is not very high. And it helps as a triaging mechanism to figure out who needs to come in for a physical visit and a consultation and who doesn't. So when the vast majority of patients on follow-up don't really require anything more than a good history and probably a physical examination, I think it's a very useful tool. Where we found it less useful is for patients who've been on active treatment and who don't have a local oncologist to kind of cross-consult based on which we could make a decision. But when we look at the impact that it's had on avoiding crowding at the Tata Memorial, I would say it's been a huge success because close to 80% of the patients whom we contacted on routine follow-up avoided a physical visit to the hospital. And I think that's been key to our avoiding crowding at the hospital.
Thanks, Pramesh. Sharon, did you have comments about telehealth specifically in the Zambia context?
And this is especially for treatment. What we see is that we have the screening program is going to end up, we kind of have the confirmed histological diagnosis, and we have to pass on to the treatment team as well. There's that, and we find that sometimes we get delays of the patients coming over because we have one chemoradiation center, and also that some of the assessments are not done on time. What has been envisioned now by the treatment center is having MDTs virtually to involve even the gynecologists in the provinces so that we can be able to work out these patients to reduce on their time and cost when they come and reach our treatment centers, so they can be able to talk to the gynecologist on the other side of the patients that they have a diagnosis of and request certain things that can be done, and then they can be able to come for treatment instead of the patient coming when maybe they could have done the full blood count, the HIV testing, the ultrasound, and all those things right in their places and reduce on their costs and time of stay at the cancer center. So it does have a place. And of course, when we talk about telemedicine, includes telepathology, which is really, pathology is a big hurdle to treatment, to cancer control in our area. And I think one of the ways we have to overcome this is really ensuring that telemedicine comes in form of telepathology to help to circumvent some of the problems that make us have poor outcomes.
Yeah, thanks, Sharon. Maybe I'll just echo quickly. You know, I think cancer care, I think historically has been a field that has been somewhat resistant to telemedicine. I think because the care is thought to be so intensive and individualized that it makes it difficult to kind of apply telehealth models, which have been, I think, more rapidly adopted in other disciplines within medicine. I do think COVID has, you know, really exposed some of the weaknesses of those arguments that, you know, this is a method that can be applied successfully. And certainly in the US, we've seen a lot of shift towards, you know, developing reimbursement mechanisms, you know, allowing telehealth for patients participating in cancer clinical trials. But I think, you know, I just want to echo both of what Sharon and Pramesh said is I think we're also recognizing the limitations of this approach. And again, I think some of what is required is really studying, you know, where this works and where it doesn't in cancer control, you know, through implementation science and other efforts. And some of those important questions, I think, you know, we are beginning to try to think about how we might address at the NCI, so specifically, so.
All right, thank you. Over to you, Sanjeev.
Looks like you're on mute, Sanjeev.
As a continuing with cervical cancer, in the face of this pandemic, Marion Seville from Melbourne, Australia wants to know, how do we maintain a momentum to eliminate cervical cancer in the face of the pandemic? Now, Zambia has offered a really nice electronic registry where you can obviously go back and track the people who missed their vaccination. What about the rest of the world? What are we doing to make sure that this pandemic still does not interfere with our goal for elimination of cervical cancer?
Sharon, do you want to start there, or?
Yes, I can start. I think when you look at cervical cancer elimination, the first stage that we have to look at is where different countries are currently. And even if you look at low and middle income countries, or you look at, for example, African settings, you look at countries like Zambia and where they are and what it is that they need to do. And in the face of COVID, the challenge, like I mentioned, that has been posed is how do we go ahead accelerating? There's the use of virtual interactions like we're doing now. And I think these can also be applied to quality improvement, to part of training. Unfortunately, some of the training is really has to be hands-on skills transfer to people that you're training, but you can be able to look at what parts can we be able to move to virtual. We're discussing issues of telemedicine. How can we be able to tap in? It's assessing where the countries are and being able to start from there. If you look at issues of HPV testing, for example, of course, it comes with its own challenges. But when looking at self-sampling, that means that we're reducing the contact time between that woman and the facility as well. And we're trying to avoid, and that can also lead to scale up because we're trying to use a method that is reducing that woman's time with the facility or in contact with somebody else. So when we look at setting up programs, importantly is that we have to know the roadmaps of these countries in forms of their strategic plans. If they don't have, how do we make sure we help to move those strategic plans? Choosing interventions that are relevant, and I think that's where implementation science comes in, Satish. Choosing interventions or choosing methods that are relevant yet scientifically accurate for the different settings. And if we're going to use self-sampling, we try to look at different areas, cost effectiveness and all come into play. So we can still be able to look at methods which are going to reduce these women coming to us. How are you using mobile technology, for example? Can we use mHealth to raise awareness? We've used mHealth before in Zambia and saw a 6% increase of uptake in services so that women can hear about awareness. You find that some countries have over 90% mobile network penetration. Can we use that effectively to be able to get messages to women so that they can be able to hear, and messages which are culturally sensitive, but still being able to reach many people? Because even in the rural area, you find that they have these cell phones, but maybe they're using it just to communicate with other, family members. Can we use them strategically to increase their knowledge on cancer of the cervix? And that can also lead to improving the access uptake of some of these services as we look at elimination. I think I can pass on to Pramesh.
Thank you, Sharon. I really have very little to add to that. That was a very comprehensive response that you gave, except for the fact that I would just add some of the benefits of COVID has been that people have been far more willing to embrace technology. They've been looking at more unconventional ways of all aspects of healthcare, whether it be screening or actual consults. And I think that's something that we could leverage to our benefit and make sure that the losses that we've had over the last 6 months with not just cervical cancer, but practically every aspect of healthcare, whether it's stroke, cardiovascular disease, and several other aspects which have suffered, can be reversed in a fairly rapid manner.
Yeah, I just want to add just quickly for context that, I think even despite COVID, I think we shouldn't understate the importance of the adoption of the recent WHO resolution, which I think, sets these really aspirational targets that and arguably is, perhaps the biggest sort of coordinated global cancer control undertaking, ever sort of articulated. So if you look at some of the kind of mathematical modeling data, this is a decades-long project to sort of decrease cervical cancer incidence to below 4 per 100,000, this kind of generally accepted incidence level that defines rare diseases, so which is how elimination is defined. And in some of the modeling, it may take as long as 100 years. So I think we're really at the outset of this. And again, I think as both my colleagues have alluded to, COVID hopefully will offer some opportunities to introduce new efficiencies that would accelerate progress towards that goal. And that may be things like mHealth, that may be things like single dose vaccination schedules, which as most of know are being kind of very intensively investigated in a number of different parts of the world. Better triage mechanisms for women being screened, so that again we improve efficiencies all along the cascade to try to achieve this aspirational goal.
Yeah, thanks, Satish. Yeah, and Sharon. Yeah. I was just wondering, could you tell us what steps can be taken? This is Laura Makaroff, who is a leader in the American Cancer Society in the United States, and she's asking, what steps can we take to make patients less afraid to come in for care and for engaging in care? Essentially, lots of people are just so fearful right now of coming into a hospital or coming into a clinic.
Yeah, I mean, I guess I can start. I mean, I think that community engagement is such a critical piece of all of this. I think there was a consistent theme through all of the talks about the importance of flexible kind of science-based policies, and then real community engagement, and not just with patients and citizens, but also with, as Pramesh discussed extensively, even with staff within Tata Memorial Center, to getting everyone kind of on the same page. So I would love to hear their thoughts. I'm going to amplify the question a little bit, in the sense that, given that community engagement is so important for the success of cancer control in general, and certainly under COVID conditions, have you all largely been doing, using the community engagement tactics that you had before and just enlarging them, or are there new approaches to sort of community engagement that you all have found necessary to deploy, to address some of the issues that the question alluded to?
Yeah, you can go ahead, Pramesh.
Sure. So what we've actually done is a combination of both. We've stuck to established ways of engagement and communication, because to me, now more than ever before in the pandemic, I think this is the key to making sure it doesn't escalate to something much worse. And it's constant communication, getting the narrative right, making sure that what we know works is disseminated across the community. That's going to be the differentiating factor between countries who do well and those who don't. Having said that, I think there's been increasing engagement in social media as well. So though social media comes with its own problems, with fake news having multiplied exponentially after COVID broke out, it's also been a very useful mechanism of disseminating reliable information as well. And at least both within our own employees as well as within our patients, we found social media to be very, very effective in disseminating best practices. And it's kind of forced us to engage with the community in a way that we never did before. And I think this is, again, one of the important aspects that COVID has brought out, the importance of getting the public involved in what should be the main discourse of our strategy.
So I just want to equally concur with what Pramesh has said. It's the use of the usual traditional partners that we have. We're looking at traditional leaders that we have in the country. You're looking at political leaders. It also has been consistency by the Ministry of Health to say routine services are continuing. You can go. But one amazing thing that has come with our social media, I know we have a platform in Zambia, it's called Teal Sisters, Teal for cervical cancer, which was set up by a cervical cancer survivor. And initially, it was a few people, but right now it has close to 140,000 women, and some of them are actually not even from Zambia. So what happens on that platform is that then us, the technical people, decided to be part of this movement instead of letting the survivors alone be given the message, is that we have different topics that we discuss and we bring in a professional. So we can bring in someone from the treatment side who discusses how treatment is done for cervical cancer. We can bring in a nurse to talk about screening. We can bring in, and what has improved is that even when they were, can we still go for screening while there's COVID? And you answer that, and somebody can come and talk about COVID and screening. We can talk about HPV testing. We talk about, nutrition and such things. This has been of great help. And you see that women are proud to be screened. They show their screening cards when they go for screening. We had intense discussions on HPV vaccination, the myths and misconceptions. So we have seen there's a way that you can actually engage people on social media. And we let somebody who the community connects with, somebody who can say, look, I had cervical cancer myself. But then you as professionals, you as technocrats in that area, come in and start giving these talks, 1 hour talks in the evening. And we can have a gynecologist discuss, we can have a gynecologist, and people can ask questions. This has really helped to a large extent. You can go, of course, it's limited in that some people won't be able to access it in the deep rural areas, but you'll find that it does reach quite a huge audience. It has a great audience that listens, and you find you can, and hopefully we can be able to write a paper that we can able to substantiate what we see, which is just anecdotal.
Over to you, Matt.
Okay, thank you. This is a question from Purnima Madhivanan. A question about stigma around being diagnosed with COVID. And Purnima says that what we've seen in our communities in southern India is that people are refusing to get tested for COVID despite knowing that they've been exposed to known cases of COVID. Is this something that you're seeing in your communities? And if so, what impact might that have on cancer care?
Mesh, do you want to start with this one?
Sure. I did respond to Purnima on the chat function, but nevertheless, so I think it has been a major factor why patients don't want to get tested. So two main reasons. One, the fact that there is some stigma associated with being tested positive. And the next are just the logistics of how do you deal with somebody who's tested positive. The challenges of isolation, even if you're mildly symptomatic or practically asymptomatic, how do you establish home isolation? And in India, an important aspect has been the way neighbors and others across who live close by have responded to this. And it's showing the ugly side of society and how intolerant we've become and how self-protective we've become as a society, that as long as it doesn't affect us, we've been happy going on with life. But the moment there is even a remote danger of getting the disease transmitted to us, we have our armors out. You convert your building into a kind of a fortress, to the extent that there have been major social repercussions because of this. And this is something that we certainly have to change. It's a much less now than it was 3 or 4 months back, but it's still not gone away. And I think this is where the narrative needs to change and where we need to make sure that our communication is spot on.
Sharon,
I think, yes, I think from the Zambian perspective, of course, we had stigma. It was seen as a disease of the rich, because the first cases came, people who had gone on holiday to Europe and then, were found with a diagnosis. So people thought, so if I don't travel, I don't get COVID. It's for people who've traveled somewhere. And after that, we could still see, because of those people's connection or other people, it was still more in the low density areas. And then, of course, there are people who work for them, there are places where they go to, and they started spreading. I think one mitigation that the Ministry of Health has used is to have testimonies and having people who've had COVID before. We have what are called daily updates on COVID to give the numbers, how many people, how many cases we've recorded in the last 24 hours, which are usually chaired by the Minister of Health or the permanent secretary in the ministry. And on these, we also bring people who've been treated for COVID, and they come and share a story. They share a story of where they've been, and to also bring reality, have a walk through the COVID ward, somebody virtually joining us from there and talking about it, and seeing people from different walks of life, people who are coming from low residential areas and people who are coming from high residential areas, some people that they know, some people that they don't know. But this brings a reality that it can be anyone. You can be rich, you can be poor, educated, not educated, and still have COVID. And that has helped in reducing stigma towards COVID, but it doesn't completely take it out. Like he's saying, if they find me with COVID, and some people, because initially we had COVID, which was very symptomatic, people were, I have COVID, but nothing. And then we started seeing another wave where we're having people who were really sick and people were beginning to die. So we needed to talk about it and open up so that people can be able to come early and get treatment. But it's still a challenge. Engaging religious leaders has also helped a lot so that it can be spoken about on various religious platforms that are available.
Yeah, I might just add, the other thing just to mention is, in addition to social stigma, there's of course really practical everyday economic implications for a lot of people in coming forward to be tested. Not everyone can telework, and when your livelihood and sort of feeding your family depends on, being able to move around and interact, as a market vendor or a small business owner, I think that's another very powerful disincentive for people to get tested in addition to stigma.
Thank you. And then there are a couple of specific clinical questions. One is from Lynn Kohlmeyer. Is there evidence that patients with lymphoma or leukemia not currently on immunosuppressive therapy, but with active disease, might still be at a higher risk for COVID-19 if exposed?
I can start with that one and then maybe hand off to Pramesh. I think, I think a lot of the data about how COVID and cancer specifically interact is still being generated. Again, I tried to review some of this in my talk, that it does seem that certainly the risk of severe complications is much higher among cancer patients than among people without cancer when they're infected with COVID. And that seems particularly true for people with advanced or progressing cancer, both in solid malignancies and in hematologic malignancies. There's a number of efforts that the NCI is supporting to really understand this interaction a little bit better. I think the expectation is that having an underlying hematologic malignancy would be somewhat immunosuppressive and would create an increased risk, but I think there's a lot about that we will still learn. The NCI is supporting a large natural history study of cancer and COVID across the United States, in addition to supporting a number of other efforts that are COVID related. At the website that I had indicated at the end of my slides, viewers can find out much more about that specific effort and others to address these sorts of questions. Pramesh, I don't know if you had anything to add there.
Right. So I think Satish was spot on with what you just described. Patients with malignancy do much worse than those without malignancy when they contract COVID. And amongst those with malignancy, the ones with hematological malignancies do worse than those with solid tumors. This has been our experience as well. So it's actually come to a point where, though we are a designated hospital which treats patients with cancer and COVID, we sometimes are in a situation where we are forced to triage. And there we would rather take the hematological malignancies indoors first, because they are the ones who are in more acute need of care and are likely to deteriorate fairly rapidly if that care was not given. And Satish, with your study with the NCI's funding, you should probably support us, because we got one of the largest cohorts of cancer and COVID globally.
Great. Well, I didn't realize this conversation was going to result in a funding request, but thanks, Pramesh, for that. So,
All right, thank you. Another clinical question. This is from Yash Javeri, and others have asked similar questions. So can you comment on the coagulopathy in patients with cancer who also have COVID-19? Is the coagulopathy more severe than that which you would normally see in a patient with cancer?
Yeah, so I should say at front, I'm not an expert in this, in the coagulopathy features specifically. I do think that, much of the complications of severe COVID seem to be related to hyperinflammation, both the lung pathology as well as some of the hypercoagulability features. And many of the investigative treatments that are being studied for COVID are, actually have an immunosuppressive effect. Including acalabrutinib that I already mentioned in my talk, as well as tocilizumab, several IL-1 targeting, IL-6 targeting. There's also, an intense interest in, how focusing or intervening on the possible coagulopathy might also have an effect in COVID-19. I think this is all still sort of under investigation, and I wouldn't say that there are clear answers about this currently, but I think we will learn more in the months to come.
All right, thank you. Over to you, Sanjeev.
Yeah, this is more of a philosophical question, but I can't think of any other panel that can address it better than you. So I'm going to pose it for you. This is Collins Akumabor from Lagos, Nigeria. And the problem he's trying to tackle is, of course, there is so many new medicines coming in cancer, so expensive, biologics, and so much new science and targeted and individualized medicine. So his question is, how can cancer care be made more affordable for patients who lack health insurance?
I'm happy to start. I don't know, Sharon or Pramesh, would you like to get to your immediate thoughts on that, or?
You go ahead. I'll chip in later.
Sure. I think this is a really important issue, and I guess this is an issue not just for LMICs, right? Even in the United States and in Europe, the cost of some of these newer agents, I think is really putting a serious stress on, on health systems. I think there's a variety of solutions to this. One, I think, is, doing studies that, being really clear about what the likely benefits of these medicines might be in LMICs, so that you can prioritize the medicines that are likely to be highest yield. And I think that requires rigorous clinical studies as well as cost effectiveness analyses that can really inform these discussions. I think it's, unlikely that patients, again, this is true even in the United States, that every patient gets any cancer treatment that would have any benefit for them. I think that's not a realistic world most likely, but we want to ensure that, again, ministries are able to use their resources adequately to sort of ensure the health of their populations. I think there's a lot, both clinical studies and cost effectiveness studies, as well as engagement between scientists and policymakers and pharmaceutical companies, these sort of multi-sectoral initiatives that I think have happened in a big way for HIV, but are just starting to happen for cancer, but really don't have the scale and maturity that they have for HIV yet. So I think that's one obvious thing. The other thing is, I think sometimes policymakers just view cancer care as prohibitively expensive. And again, I think that's where, we have done some of this work in Malawi, which is where I lived and worked for a long time before coming to the NCI, really trying to demonstrate that some of these newer medicines can be applied in the local context, can result in improved outcomes, and that formal rigorous cost effectiveness analyses can actually demonstrate that these make sense even using WHO metrics for LMICs. With cancer care, particularly in the curative setting, you're often spending money upfront for potentially many decades of event-free survival subsequently, and that you have to be willing to make those investments upfront, as opposed to HIV, for example, where you're paying the daily cost may be lower, but those are over a lifetime. So again, I think these are both the science and the advocacy has to be done with the right combination of stakeholders to really address this important issue. That's a big philosophical answer to a big philosophical question. So I'll hand it over to Sharon and Pramesh, who I'm sure will have other things to add.
I think other than that, we find that, of course, there's some WHO guidelines on some of these drugs that they have done, the costs and the outcomes, which can help countries to be able to determine what they can work with. I think we need, as countries, as continents, we need to be thinking of access in terms of regional blocks instead of going as countries. And that can be achieved. Of course, cancer comes differently for different cancers, but we know, let's say Zambia, Malawi, they know their commonest cancers. We're not going to be able to get to every cancer, but you know that cervical cancer is leading in Zambia, cervical cancer is leading in Malawi, is leading in Swatini. What should we think about as a pooled procurement for something, we're going to get so many women. We have breast, we have this, there's some drugs that can be pooled by these blocks and be bought at a much more lower price than when countries go on their own with a few patients. And of course the pharmaceuticals are also looking at profits and everything. So I think in most of our cancer care, even when we're talking about testing for HPV testing, which could be prohibitive, I think we should learn to now look at how do we make volume, how do we be more, but it's looking at costing, it's looking at the type of drugs and other alternatives that are available that countries can engage in, but only if there's a way of coordination. I think what you're talking about, the stakeholder ability, we really don't have so much coordination at a certain level where we can channel this and be able to do this either as a block, either as a continent, as countries or something. Sometimes it's lacking. Of course, there are other drug access initiatives for cancer that are going on that countries are trying to see if they will help at all. But it's a difficult question. It's a difficult question. Very philosophical. Yes, I agree.
Yeah, great. I think I'd agree. It's a really great question, and probably, Sanjeev, the topic of your next hour and a half webinar on value-based cancer care. It will really make an excellent topic for a session on that. But I think it's really important, especially in countries like ours, where public healthcare expenditure is much lower than what it is in other parts of the West. And when you're dealing with that really small pot of money, trying to manage care for 1.3 billion people, you need to be very, very careful about where that every single rupee or dollar goes. And I think that's key to optimizing the use of fairly expensive cancer care. I just have one additional thing to say, and that's a pet peeve which I've had with cancer physicians, which is hyping the margin of benefit that you normally see with breakthroughs. So when you ask any cancer specialist what have been the breakthroughs that they've had in cancer care, you hear about imatinib for CML, you hear about ipilimumab, nivolumab for melanoma, osimertinib for lung cancer, crizotinib for ALK-positive lung cancer. These are genuine breakthroughs. But if you look at the vast majority of cancer drugs that have got approved by the US FDA, there's a really nice study that's come out of the US where they looked at 71 consecutive drugs approved by the US FDA for cancer care, and the margin of benefit, both with progression-free survival and with overall survival, was just 2 months. And compare that to the exponential increase that you had with the cost of care. On a logarithmic scale, it beats the level of inflation that you see normally. And that's really not good value-based care that we're providing. So the first thing I would suggest is to have a robust health technology assessment to evaluate whether any intervention that we suggest as part of a guideline is value for money. And second, that oncologists stop hyping the margins of benefit of new drugs that come into the market.
Thank you, Pramesh. And I think that there's been precedence in HIV when you have the kind of disparities we have in cancer, where children are dying in Africa from pediatric oncological problems, 70% mortality versus 20% in the US. I think that it's probably time for us to have a similar move in cancer like we had in HIV to reduce disparities and getting these drugs very inexpensively to everyone. There are a couple of questions that I'll take a very quick. One is how can Gulu University be supported to introduce cancer care to its spokes? So of course I don't have the answer to that, but if you're interested in having in us providing you ECHO to have a network with your spoke hospitals, we would be delighted to do that. And I'll put my email in the chat in case you are interested in doing ECHO there. And the one question was, will the slides from this presentation be available for printing? The answer is yes. And in a couple of days if you go to our website. But back to you, Matt.
Thank you, Sanjeev. And Dr. Gopal, anything else before I give a couple announcements?
No, thank you again for the opportunity to moderate this amazing session, and thanks to Sharon and Pramesh for joining me in this, I think, really important and timely conversation this morning.
Thank you, Satish. And to conclude today's sessions, we'd like to thank our panelists, our presenters, Dr. Kampambwe, Dr. Pramesh, Dr. Gopal for presenting and also moderating this session. Thank you all for sharing your time and expertise with us today. And of course, thank you to everyone on the network who joined us for this ECHO COVID-19 Global Conversations session. The CME link is in the chat box for you to complete a survey and obtain your CME and CEU credit. And please watch for future announcements at our website. We'll put the web page, the web address in the chat box. And we'll put information about future sessions on our website, any updates and information. And then thank you again for your continued interest in Project ECHO special programming on COVID-19. Thank you all. Bye.